Okay, so now we're going to start talking about oxygen devices, low flow versus high flow devices. So, quick definition of what I mean by high and low flow. Low flow means that the device flow. So, if you're thinking about device, you're thinking about a nasal cannula or a simple oxygen mask. The device flow is always less than the patient's inspiratory flow rate in a low flow device. Always, always, always. Oxygen is always being diluted by room air that is being provided by the patient. What that means is if you are on a low flow device, the device itself that you're on is not going to be meeting your inspiratory flow needs. So when you think about your tidal volume and your respiratory rate and how much air you bring in a minute, right? The device that this patient is on, if it's categorized as low flow, it is not providing all of the volume for that tidal volume. So because of that, the patient's going to be inhaling the oxygen from the device, but they're also going to be inhaling room air from their surroundings to comprise of their total tidal volume. So it is considered a variable FiO2 because you have no idea how much room air they're bringing in versus how much oxygen they're getting into their actual lungs. And I know that's kind of a confusing way to say it, but basically the device that they're on is not providing all of their inspiratory flow needs, which means they have to get that from somewhere else. They get it from the room. So it is impossible for us to know exactly how much percentage of oxygen is actually making it into their lungs. We know that a patient is on, let's say, for example, a 4-liter nasal cannula, but we don't actually know that the full percentage of oxygen from a 4-liter nasal cannula is getting into their lungs because potentially that patient is bringing in larger amounts of room air than another patient is. So big takeaways. Device flow is always less than patient's inspiratory flow rate. The oxygen is always diluted by room air that is being brought in or provided by the patient, which makes the FiO2 variable, which is why we would report liter flow and not FiO2. That's why you see 2-liter nasal cannula, 3-liter nasal cannula, and you don't see 34% nasal cannula. On the flip side, a high flow device always exceeds the patient's inspiratory flow rate, which means that all of the patient's tidal volume is being provided by the oxygen device. So that means that if the oxygen is diluted, it's only being diluted by the device itself. So for example, on an oxygen blender, there's a proportioner where you can set it to 50%. So in that situation, the device is diluting that oxygen to 50%. So it's pulling in the room air to make that FiO2 50%. The patient is not diluting that oxygen at all because the device itself is meeting that patient's entire inspiratory flow needs. So it's always going to be a fixed FiO2. The FiO2 can be low or high. You can have somebody on a high flow device that's only on 30%. But the FiO2 will be precise. So high flow does not necessarily mean high FiO2 in the same way that low flow does not necessarily mean low FiO2. The definition for low flow and high flow is exactly what it says on the slide. It just relates to the patient's inspiratory flow needs. So high flow always exceeds patient's inspiratory flow rate, and a low flow will never, ever meet the patient's inspiratory flow rate. So that's one of those things where it takes a little bit. We'll practice it a lot, but that's the basic definition there. So examples of the low flow devices that you guys are going to be learning about. We're going to talk about the nasal cannula. We're going to talk about the simple oxygen mask, the partial rebreather, and the non-rebreather. Eventually we go on to talk about the reservoir cannula. This is not a big part of what we talk about, but you'll get to see it in lab. And then this transtracheal oxygen, know that there is very, very little. I'm going to ask you about this. This is a very low use device. It's one that still comes up every once in a while for a patient that comes in. I've seen it, but not very often. So that's going to be a small little snippet of this entire lecture here. So again, low flow is a device flow that's always less than the patient's inspiratory flow rate. Delivered oxygen is always going to be diluted by the room air that the patient is bringing in, which makes it a variable FiO2. And then again, just really not thinking that low flow means low FiO2. You can have a very high FiO2, but be on a low flow device, okay? And we'll talk about that more as we go through the devices. So this is just a picture of the nasal cannula. So nasal cannulas are usually used with flow rates of 1 to 6 liters per minute in adults. You don't want to go up more than 6 liters on a standard nasal cannula because it starts to get pretty uncomfortable. In infants, you can get flows as low as a quarter liter. Anytime you're on more than 4 liters per minute in an adult, you want to add humidity, and it's called a bubbler, and we'll see those in labs. So how you can kind of estimate the FiO2 of a nasal cannula, and again, we don't report the FiO2 because it is a low flow device, is that for each liter, you get about 4% of increased oxygen. So if you're thinking about room air being 21% oxygen, we use 20 for the ease of math. You'll see that room air often gets rounded down to 20% just for ease of math. So 1 liter would be 24. 2 liters would be 28%. 3 liters would be 32%. And so on and so forth. So it's kind of a guesstimate rule, the rule of 4%. So just 20 plus 4. So this kind of shows an example of how we kind of guess the percentage of oxygen that's being delivered per liter flow. That being said, because it's a low flow device, we never chart 24% oxygen because we don't technically know for sure that they're getting 24% oxygen because the nasal cannula is not meeting the patient's inspiratory flow needs. Advantages of a nasal cannula. It's easy to use. You can use it on all patients. It's low cost. It's well tolerated. Big disadvantage, it's very easy to dislodge. I'm sure you guys have seen that. Higher flows can be uncomfortable, can cause dryness and bleeding. If you have a patient with any sort of like deviated septum or nasal obstruction, or if they're very heavy mouth breathers, that can severely reduce your FiO2 that's being delivered. So if you have, just to kind of reinforce that whole patient inspiratory flow needs, if you have 2 patients, both on a 2-liter nasal cannula, and patient A has a tidal volume of 650 and patient B has a tidal volume of 400, if you could measure the FiO2 at the crino, which patient do you guys think would have a lower FiO2? And all this is trying to show is that more than likely the patient with the bigger tidal volume is going to have a lower FiO2. This patient's inspiratory flow needs are higher than this patient's, and so they would be bringing in more room air to meet their inspiratory flow needs, thus diluting this 2 liters more than this patient would. And that's just, again, circling back to that low flow device definition. Okay. This low flow nasal catheter that we talked about, or transtracheal catheter, is rarely used in modern healthcare. It may be used during bronchoscopy or other procedures. We're going to skip. This is one of those nasal catheters here. The transtracheal one that goes in here, that's something that some patients use for home oxygen. Again, we're going to talk about them really briefly in lab. You're not tested on them. I just leave them because every once in a while you see it, and it's nice to at least have a frame of reference. The next big device that we're going to talk about is a simple oxygen mask. I gave you guys a grid to look at all the O2 devices that break up the percentage and the flows and things like that. Big takeaway for the simple oxygen mask is you cannot use them at less than 5 liters per minute. And the reason why is they've got these exhalation ports, but if you're not on at least 5 liters of flow, then it's not enough to flush the CO2 out of this mask because this mask covers their nose and it covers their mouth. So if you have this set at 3 liters per minute, it's not going to be enough to flush out that CO2. And then you create a scenario where they're rebreathing their own CO2. And that is not something that we want. This is something that you commonly see because people will come in with simple oxygen masks from other facilities. And I have seen them set below 5 pretty consistently because they'll look at a patient that's saturating well and they'll just turn down the leader flow. It's very, very dangerous. These can never be used at less than 5. You also have your partial rebreather and non-rebreather. These are the other low flow devices that we are going to be talking about. There's another PowerPoint where there's pictures of this that we can talk through. We're going to talk through these right away when you guys come into class. This is where the hands-on stuff gets to be very, very helpful. Big takeaway is you guys are responsible for all the percentages, all the leader flows, which are on that grid all together in one spot. And this is why I say don't confuse low flow with low concentration. A non-rebreather delivers 60 to 80% FiO2. These ones have a minimum flow rate of 10, and that has to do with the reservoir bag that they have, which you guys will see on the next PowerPoint. The big thing with these is they both have reservoir bags. So how do you know if the liter flow is high enough? So these can go from 10 to 15 liters. The way that you know that the liter flow is high enough is that the bag does not collapse, and that's going to make more sense on the next PowerPoint. So we'll kind of circle back to that. This is the reservoir bag. This has to be filled before you put it on the patient. And what this does is it holds oxygen so that when the patient breathes in, they get a very concentrated form of oxygen and are less likely to entrain as much of their own room air. If this bag is collapsing down, it means you need to turn the liter flow up because it means that they're emptying the oxygen reserve out of there, and you guys will see that when we play with them in lab. The big difference between a partial rebreather and non-rebreather is these are your exhalation ports, and then there's also kind of a plastic adapter here that you guys will see. The partial rebreather doesn't have any valves. This is open, this is open, this is open. On the non-rebreather, there's a one-way valve here and a one-way valve here. And what that does is it just ups the O2 concentration, and that's what makes it a different mask. It's also why this has a higher concentration of FiO2 delivery than this one. So advantages of masks in general, either the simple mask or the rebreathing masks, is you can get a higher FiO2 than you can with a nasal cannula. They're quick and easy to apply. They're disposable. You can use on all patients, and they're great for those patients that are mouth breathing. The disadvantage is patients generally find them more uncomfortable. They got to be removed for eating or oral care. It can be difficult to communicate, although we're all getting much better with the mass communications, #COVID. There's also a risk of aspiration, and this is something that I've actually seen quite a bit. People wearing different masks, simple masks, rebreathing masks, CPAP masks, and then they're nauseous due to some of the meds that they're getting or the things that are going on. And if you throw up into a mask, you are more likely to aspirate it because it comes back into your mouth. So that's another disadvantage. That is it for low flow devices. And then we'll kind of move on to the high flow, and then we'll look at the pictures.